prescribed to treat depression, bladder conditions and Parkinson's are being linked with an increased risk of dementia. A new study published today in the British Medical Journal claims that up to 2 million people in England are likely to be taking one of the anticholinergics. That's not how you say it, is it, Helen?
Pretty good.
Go on, how do you say it?
Anticholinergic.
Oh, it's terrible. Anticholinergic, thank you. Okay, here to talk about this further is Helen, who you've just heard from, Professor Helen Stokes-Lampard, who's a GP and chair of the Royal College of General Practitioners. Also with us, Professor Chris Fox, who's a consultant psychiatrist at the University of East Anglia. And he has been working on this study for 10 years. And Dr. Claire Walton, who is the research manager from the Alzheimer's Society. They've actually funded the research. Okay, so let's talk about the research with Chris Fox, first of all, who's right behind you, Helen, if you have a look. Good morning to you, Professor. Tell our audience, who might be alarmed at hearing this initially, what you found.
Thank you, good morning. So we found in a study of 300,000 people that there was an increased risk of certain types of medication with the instance of dementia. And the types of medication we found were antidepressants of certain types, bladder medication and Parkinson's medication.
And what should we do as a result of what you found?
Well, I've been doing this for some time in other areas, but I think what we need to think about is medication review and medication management. So this actually sharpens up the focus on these particular drugs and the risk for dementia. So my view, and what I'm doing clinically at the moment, because I'm clinically active, is when I see people on these medicines and I haven't prescribed them, I write to the prescriber and say, you may consider alternatives. But if I prescribe it, then I discuss with the patient the risks, consider lifestyle factors, if they've got any comorbidity, and then between us we make a decision. I mean, the good news is that there are equally effective medicines that are no more expensive that don't do this.
There are equally effective medicines that are no more expensive that don't do this. Okay, let me talk then to Claire Walton, research manager from the Alzheimer's Society. You funded this research, and how do you react to the outcome?
We think it's very important, and these medications have been linked to an increased risk of dementia before, but this is the largest and most robust study to kind of really follow up on that, and we think it's large enough and that the data is strong enough that prescribers should really be considering the long-term prescriptions of these drugs.
Sorry, just be clear, how much of an increased risk?
So it varied for the types of medications, but up to about a 30% increased risk with some types. So we're not talking a huge increased risk, and we are talking over quite a long time. So people shouldn't be rushing out to stop their prescriptions, definitely not. They don't need to take urgent action. But if they are concerned, they should go and speak to their GP or their pharmacist. And it's something that we should be thinking about in the long term, because there are safer alternatives available in most cases.
Okay, sorry, you said a 30% increased risk, did you?
Up to 30%, depending on the different types of drugs. Okay. Lots of drugs were studied in this.
So it could be 1%, it could be 30%, depending on the individual and depending on the kind of drugs they're taking. Right, Helen, you're a GP.
Yep.
You will potentially have people coming to you now saying they've heard a little bit about this research. What should they do? Because they're taking some of these drugs and they're worried about an increased risk of dementia in the future. What will you say to them?
The first thing I'll be saying is don't panic. This is really useful research, it's good research, it's high quality research, and it just adds to what we already know about various drugs, that some of them do seem to be associated with a high risk of dementia, but we haven't got proof that it's causing dementia, and that's a really important thing to understand. Sometimes these drugs will have been given to people who may be starting to develop dementia because some of the symptoms associated do need treatment, perhaps for low mood, may need help with bladder problems, and so sometimes it's the people who are already developing dementia are given the drug. So it's a little bit complicated to unpick. The last thing I want to be doing is
sorry to interrupt, but as Chris Fox has already said, there are alternatives that don't do this.
There are, absolutely. And we've got alerts in computer systems in general practices warning GPs when we see these combinations of drugs that are particularly shown to have an increased risk, saying, oh, is this the right drug for this person? And we would hope that as this evidence is merged with other evidence, we'll get even better at that. It's saying, this older person, this person who's already frail, already got some risk factors, we shouldn't be putting them at even more risk. However, for some people, these are the only drugs that work, and I think we need to be careful about that. If you're depressed and we finally found an antidepressant that's really helping you and enabling you to function, or you're an older woman whose bladder problems are really significant, you've been stuck at home and unable to go out, Actually, it's weighing up the risks and benefits of these drugs compared to the individual patient, but it's about the individual.
Okay, let me go back to Chris Fox. Would you agree with that last sentiment from Helen, RGP?
To an extent, but I'd also like to add the issue of whether the patient actually needs to take the medicine anymore anyway. It's very difficult to stop antidepressants because you worry about the illness coming back. Similarly with bladder conditions, I've worked quite extensively in that field in the last couple of years lecturing, and the feedback I've had from prescribers is that they worry if they stop it, it'll get worse. And why, I often say, sometimes if they're not suicidal or none of these conditions are going to kill you, sometimes having a medication holiday and then review it rather than prescribe anything else is the best option.
With depression, I would be very, very cautious. We would try and wean drugs down very slowly. Certainly trying to get people off medication they don't need is a great practice, but it takes time. With medication for bladder, yes, you can certainly try medication holiday. I mean, that's a sensible thing to try, and we frequently do that. And people sometimes don't like taking these drugs for all sorts of reasons, and people often take them in ways that aren't prescribed properly. So there's lots of things. The important thing is regular reviews with a GP or the person who prescribed them, who can talk through your individual situation. So we should be having at least annual reviews anyway. We know general practice is under pressure. What I want is longer time, greater time spent with my patients so we can do this stuff properly. We're all know general practice is struggling, so I would be putting in a plea. This evidence, along with lots of other evidence, all builds to the fact we need longer appointments with our patients to give them the best quality care.
Well, you can make that happen.
I'm doing my best.
Yeah.
Everything I can, but everyone who can help.
So it's sort of 10 minutes at the moment.
And
How long should it be, ish?
At least these kind of patients, 20. Absolutely. I mean, we're aspiring to build up to 12 and 15, but 20 is where we should be going for complicated patients.
Okay. Thank you all. Thank you very much.